Welcome to the debate. We are doing something a little distinct today. You might call this a piggyback broadcast. Following our last deep dive into the theoretical weeds of cardiac physiology, our inbox was absolutely inundated.
Yeah, the feedback was loud and clear. Everyone appreciated the theory of how the ions move across the membrane, but, the overwhelming sentiment was, that's great, but what do I actually do when I'm holding that strip of pink grid paper in my hand?
Precisely. I mean, the theory is the map, but the EKG strip is the terrain. So we are back to clear up those lingering questions regarding practical application. We are going to bridge the gap between the classroom and the emergency room.
And we promise to keep it lively. We might even be a little comical today because, let's be honest, if you stare at rhythm strips for too long without laughing, you might just go into a non-shockable rhythm yourself.
True enough. Now, before we begin our analysis, we must acknowledge that this broadcast is presented by Whole Life Healthcare. They understand that whether you are analyzing complex data points or treating a patient at the bedside, the ultimate goal is always the preservation of life.
Absolutely. So let's get into the fight. The central question today is about methodology. When you are interpreting an electrocardiogram, what is the superior method for calculating heart rates, duration of pauses, and getting accurate readings? Is it the rigid mathematical box counting method, that slow analytical system 2 thinking?
Or is it the rapid, context-heavy pattern recognition method, the intuitive system 1 thinking? I, of course, represent the former. I stand for the absolute truth of the grid. An EKG is not an abstract painting where you infer meaning from the vibes of the squiggles. It is a graph of time and voltage. If you cannot measure it, you do not know it.
And I represent the clinical Gestalt method, because in the real world, when the alarms are screaming and a patient is crashing, you treat the patient, not the paper. I firmly believe that pattern recognition, informed by clinical history, is what actually saves lives when seconds count.
I understand the appeal of speed, and I certainly respect the intuition of an expert. But let me give you a different perspective on what expertise actually is. Accuracy is the bedrock of medicine. On a standard EKG strip, the horizontal axis represents time. This is a fundamental law. It is immutable. To navigate this law, we have standard dimensions. A small box is exactly 0.04 seconds, or 40 milliseconds. A large box, which is composed of 5 small ones, is 0.20 seconds, or 200 milliseconds.
I knew you were going to lead with the milliseconds. You just love those tiny boxes.
Because they are the atomic unit of the diagnosis. If you are not using these specific metrics to calculate RR intervals and P-wave durations, you are merely guessing. Let's talk about heart rate. You have the rate by boxes method, which is the gold standard for determining regularity.
Right, go on. Walk us through the math.
It is elegant in its simplicity. You find an R wave that lands on a heavy line, a large box line, and you count down the subsequent heavy lines, 300, 150, 100, 75, 60, 50. That sequence gives you an objective mathematical heart rate. If the next R wave lands on the 4th heavy line, the rate is exactly 75 beats per minute. Precise, objective.
Sure, in a textbook scenario where the heart is beating like a Swiss metronome. But let's be real. That 300, 150, 100 method is cute. It works perfectly in a classroom or on a board exam. But code blues don't wait for you to find an R wave that lands perfectly on a heavy line.
But the principle holds even if it doesn't land on the line, you just subdivide the boxes.
But in a crash scenario, the priority isn't the exact millisecond duration of the RER interval. The priority is binary. Is this a shockable rhythm, like ventricular fibrillation or pulseless ventricular tachycardia? Or is it non-shockable, like asystole or PEA?
But you identify those rhythms through their electrical characteristics, which are inherently defined by their measurements.
No, you identify them through recognition. That is where recognition prime decision-making, or RPD, comes in. We looked at the NIH study that highlights this explicitly. Experts use intuitive pattern matching because it is faster. It frees up cognitive load. If I am standing there dividing 300 by the number of boxes, I am not leading the resuscitation. I need to be thinking about CPR quality, epinephrine dosing, and reversible causes.
I am not convinced by that line of reasoning. Because it assumes that precision and speed are mutually exclusive. They are not. In fact, relying on a quick look creates dangerous blind spots. Specifically, your Gestalt method fails the moment you need to diagnose a block.
I have to disagree. A block is a pattern.
A block is a measurement. Take Mobitz type 1 or Wenkback. The definition is a progressive prolongation of the PR interval until a beat is dropped. That prolongation might only be 0.04 seconds, one single small box, per beat. You cannot feel a PR interval lengthening by 40 milliseconds. You have to measure it. If you rely on your gut, you look at the strip, you see a dropped beat, and you might mistake it for Mobitz 2.
Which is exactly why I look at the whole strip.
But if you mistake Mobitz I for Mobitz 2, you are mistaking a relatively benign condition for one that often requires a pacemaker. The difference is entirely in the small box. It is 0.04 seconds of truth.
Look, I am not saying the math is wrong. I am saying it is often impractical in the heat of the moment. And frankly, your rate-by-boxes method falls apart completely when the patient goes into atrial fibrillation. Real hearts, especially sick ones, are rarely perfectly regular. That is why I advocate for the strip method.
You mean the 6-second method?
Exactly. You take a 6-second strip, you count the R waves, and you multiply by 10. It is practical, it handles irregularity effortlessly, and it keeps your eyes on the rhythm, not the grid lines. If I count 8 beats in 6 seconds, the rate is 80. Done. I don't care if the RR interval varies by 0.08 seconds. I know the rate is controlled.
That is an estimation. It is a shortcut. And while shortcuts have their place, they are dangerous foundations for a diagnostic framework. Let's dig deeper into where estimation fails. Let's talk about the mathematics of the pause.
Ah, sick sinus syndrome.
Exactly. We see this often alternating tachycardia, bradycardia, and then sinus arrest. To diagnose a pathological arrest versus a benign pause, precision is non-negotiable. You cannot just look at a gap in the EKG and say, wow, that looks like a long time.
That felt like an eternity.
Feelings are not data. The protocol for measuring a pause is clear and must be followed. You count the number of boxes between the R waves of the preceding and subsequent complexes. First, you count the full large boxes and multiply by 0.20. For example, if there are exactly 5 large boxes, that equals 1.0 second.
Right, so you have your base seconds.
Then you count the remaining small boxes for any distance that doesn't fit into a large box, and you multiply those by 0.04. Finally, you add these values together to get the total duration in seconds.
You are literally describing a multi-step math equation during a cardiac event.
I am describing diagnostics. If you calculate a pause of 2.8 seconds versus 3.2 seconds, that distinction is massive. It can determine whether a patient needs a pacemaker immediately or just observation. You cannot eyeball a 3-second pause with sufficient accuracy to make a surgical decision. You need the number.
That is a valid point for a stable patient in a clinic who is complaining of dizziness. But allow me to retort with the reality of the double-blind study.
I assume you're referring to the joke in this source material.
I am. It is a classic for a reason. What do you call 2 medical students reading an EKG? A double-blind study.
Very amusing.
It is funny because it hits on a truth. When you rely solely on the grid without clinical experience, you are blind. You can count boxes all day, but if you don't know what you are looking at, it is useless. Let's look at that Mobitz type 2 block again. You're talking about measuring boxes to find a dropped beat. I am telling you that in a clinical setting, a Mobitz 2 pattern screams danger. It is a visual pattern of a sudden drop without prior warning.
But how do you distinguish it from a non-conductive PAP interval?
You look at the patient. This is where the grid fails and the body speaks. If you look at the neck, you might see canon A waves in the jugular vein. That physical exam finding tells you there is AV dissociation. The atria are contracting against a closed tricuspid valve because the ventricle didn't beat. The neck tells you what the grid is trying to whisper. If I see a dropped beat and canon A waves, I am getting the pacing pads, not my calipers.
I find that line of reasoning risky because it relies on the clinician noticing a subtle physical sign, which is notoriously prone to error. You are replacing one difficult observation with an even more difficult one. The grid does not lie. If the boxes say the PR interval is constant and a beat is dropped, it is Mobitz 2. Reliability is found in the measurement, not in hoping you spot a vein pulsating in the neck in a dark room.
But reliability is also found in context. You are acting as if the EKG exists in a vacuum. This brings me to the critical issue of cognitive bias versus clinical history.
I am glad you brought that up because the evidence actually supports my position on stripping away context to avoid bias. The Australian Medical Journal study is quite damning for your context is everything approach.
I recall the study.
They found that providing a negatively biased history, essentially a misleading patient story, reduced diagnostic accuracy scores by 34%. That is a third of the diagnoses wrong, simply because the doctor listened to the story instead of looking at the grid.
I knew you would bring that stat up.
It is not just a stat, it is a warning. If a patient comes in with a story that sounds like indigestion, and you let that history anchor your interpretation, you might miss the subtle ST elevation of an inferior MI. The sources show that history creates anchoring bias and confirmation bias. You start seeking features to confirm the story rather than reading the strip. To get an accurate reading, you should use the uniform approach. You read the EKG blind first using the box method to ensure objectivity. I come at it from a completely different way because you are ignoring the other half of that exact same study. The evidence also showed that when doctors were given a positively biased history, a history that pointed toward the correct diagnosis, scores were 42% higher. Furthermore, junior doctors performed 34% worse than senior doctors when they were denied history. But relying on history is a crutch if it blinds you to the electrical reality.
It is not a crutch. It is a spotlight. Let's talk about the avocados versus bananas example from the UNC source. This is my favorite example of System 1 versus System 2.
The hyperkalemia debate.
Exactly. You look at the strip, you see tall peaked T waves. Your box counting tells you the amplitude is high. But can you diagnose hyperkalemia, high potassium, just by measuring the height of the T wave?
While specific levels of serum potassium cannot be perfectly linked to unique EKG patterns, the peak T wave is a critical indicator that requires immediate verification.
Verification through context. The source explicitly states you can't just look at T wave magnitude. You need to know, does this patient have renal failure? And, crucially, did they just eat a bowl of guacamole?
The dietary intake is relevant, yes.
Relevant? It is the key. The source notes that avocados, guavas, and kiwis have significantly more potassium than bananas. Bananas have the best PR team in the fruit world, but avocados are the real killers here. If you ignore the patient who tells you they just ate 3 avocados and you only look at the grid, you are missing the etiology. The EKG is not an island. You treat the patient, not the monitor.
I see why you think that. But let me give you a different perspective on complexity. You argue that pattern recognition is superior because it integrates context. I argue that pattern recognition fails catastrophically when the pattern is rare, subtle, or mimics something else. We are not always dealing with obvious peak T waves or chaotic VFib. Sometimes the devil is in the details.
Give me an example where your boxes save the day in a way my eyes wouldn't.
Regatta syndrome. This is a genetic defect in cardiac sodium channels, a leading cause of sudden cardiac death in young men. The sign can be incredibly subtle. You are looking for a coved ST segment elevation greater than 2 millimeters in leads V1 to V3.
Which is a visual pattern. It looks like a shark fin.
It is a measurement. If you just glance at it, it looks like a bit of noise, or perhaps an early repolarization pattern, a benign variant. You have to stop, engage System 2 thinking, and count the millimeters. Is it fully 2 millimeters? Is it followed by a negative T wave? Or look at ARVC, arrhythmogenic right ventricular cardiomyopathy. The source describes epsilon waves, little wiggles or blips at the very end of the QRS complex.
Epsilon waves are notoriously hard to spot, I'll grant you that.
A gestalt glance misses a tiny wiggle. A rigorous box-by-box inspection of the QRS termination reveals the pathology. You have to zoom in, you have to care about the voltage.
That is a compelling argument regarding rare genetic conditions. But have you considered that System 1 thinking, that gut feeling, is actually built on the accumulation of those rigorous inspections? You are describing the learning process, not the expert process.
But even experts miss things when they stop measuring. Look at left ventricular hypertrophy, LVH. The voltage criteria are strict. You need the S wave in V1 plus the R wave in V5 or V6 to be greater than or equal to 35 millimeters. You cannot eyeball 35 millimeters across two different leads accurately. You physically have to count the boxes. If you don't count, you miss the hypertrophy, you miss the strain pattern, and you miss the underlying hypertension.
VH. But let's look at a killer like pulmonary embolism. You might be busy measuring the rate and access, calculating degrees, but an expert using pattern recognition looks at the strip and sees the S1Q3T3 pattern, an S wave in lead 1, a Q wave in lead 3, and an inverted T in lead 3.
That pattern is present in only 20% of PEs. It is historically famous, but statistically weak.
Agreed, it is not sensitive. But if I see that pattern and I know the patient just got off a long-haul flight, or as a young woman on oral contraceptives, information you would ignore in your blind reading, I have a working diagnosis in seconds. While you are calculating the access of the QRS complex to the exact degree the patient is throwing a clot. Analytic strategies are slower and prone to analysis paralysis during a crisis.
This strongly. Rate, rhythm, axis, intervals, P's and Q's. Every single time. This prevents you from being distracted by the obvious S1Q3T3 and missing a secondary block or subtle ischemia elsewhere. You see the PE pattern and stop looking. I finish the checklist and find the rest.
In a desk review, absolutely. Use the uniform approach. But we are talking about the showdown between grit and gut in the trenches. In a code blue, the nurse's role, as defined by the crash scenario source, is specific. Start CPR, apply pads, analyze rhythm for shock, and administer epinephrine or amiodarone.
Those are the correct steps, yes.
There is simply no time to calculate exact axis deviation when the patient is in VFib. The nurse needs to look at the monitor, recognize the chaotic waveforms of VFib, and shout, "Shockable." That is pattern recognition saving a life.
And yet, if that nurse mistakes fine VFib for asystole because they didn't look closely at the gain or the amplitude, essentially measuring the voltage, they might cease resuscitation on a viable patient.
Or if they mistake artifact, like a toothbrushing patient for VTAC, and shock a conscious person.
A toothbrushing patient.
It happens. Vigorous toothbrushing creates an oscillatory artifact that looks exactly like VTAC. If you don't look at the patient, if you don't use context, you are going to defibrillate someone for dental hygiene.
Which brings us right back to the necessity of verification.
I think we are circling the same truth here.
Perhaps. Let's try to summarize our positions in light of this discussion. I maintain that while clinical context is a helpful adjunct, the EKG is fundamentally a tool of measurement. Whether you are calculating that pause in sick sinus syndrome to determine if it is 2.8 or 3.2 seconds, counting the large boxes times 0.20 and adding the small ones times 0.04, or measuring a PR interval to distinguish Mobitz 1 from Mobitz 2, the small box is the unit of truth. Without the math, you are operating on assumptions, and assumptions kill.
And I maintain that the best ideas emerge from rigorous challenge, like this one. I acknowledge the box method has its place, particularly in stable patients or when confirming a diagnosis like LVH or Brugada. But we cannot pretend that medicine happens in a vacuum. Pattern recognition, or RPD, combined with clinical context checking for pulses, knowing the history of avocado consumption or long flights, is what makes the data meaningful. In an emergency like a PE or an MI, your gut, trained by experience, is faster than your calculator.
It seems we have an impasse, or perhaps a convergence. The sources suggest a combined reasoning approach.
Exactly. Using the grid to verify what your gut tells you. Read the pattern, then count the boxes to be sure. But whatever side of the aisle you sit on, whether our listeners are counting boxes or spotting patterns, there is one thing they shouldn't do.
And what is that?
They shouldn't go into the field unprepared. You can't rely on math or intuition if you don't have the basic tools and reference guides at your fingertips.
That is a very valid point.
That is exactly why we always mention the EKG survival pack.
It is the only way to bridge the gap between math brain and clinical intuition. It gives you the confidence you need whether you are measuring intervals or recognizing classic patterns. It puts the reference right in your pocket so you don't have to memorize the potassium content of a guava.
A worthy addition to any clinician's toolkit. Well, we have covered the mathematics of the pause, the bias of history, the complexity of Brubada, and the chaos of the code blue.
We certainly have. And remember, whether you see a grid of 0.04-second boxes or a picture of a patient's heart, the goal is the same.
Precisely. Thank you for tuning in to the debate. You can check us out on Spotify at EKG Lab Live. We encourage you to form your own conclusions on the grid.
And maybe check if your patient just ate an avocado. Goodbye.